All right, so we're going to get rolling with chest pain episode 2. So if you remember, the big 7 are up there, okay? And then we've got our all causes. To review, differential diagnosis formulation really has 2 flavors. In an unstable or potentially unstable patient, you always have to think worst first. In a stable patient, it's a little different. You have more time to sort it out, and you might think about it as most likely first and then put the potential disasters at the end of the list. When we work up chest pain, we always want to rule out the big 7 first. We do that on the basis of the history, the physical exam, ancillary studies, and clinical decision-making rules. And then we make a diagnosis and we begin treatment. If we have any concern for the big 7, while we're in the process, you would want to call your attending. If not, and even if so, after you call your attending, you want to write an encounter note that includes the reason you were called, the subjective section, objective section, and assessment and plan. So if it's an H&P, that's going to be covered in your H&P. But if you're being called to the floor, then you're going to want to write an encounter note. Okay, so let's go to cases. So you're called to the emergency department to admit a 53-year-old man with chest pain and an abnormal EKG. Mr. S is 53, significant past medical history of GERD, comes in with 5 days of chest pain, 24 hours of increasing dyspnea, 12 hours of dizziness. The chest pain is a constant dull ache. Dyspnea began as dyspnea on exertion, and now he has dyspnea at rest. He qualifies his dizziness as feeling like he's going to pass out. It's more pronounced when he stands. He also notes orthopnea. Okay, so let's go through what are the big 7? Okay, ACS, dissection, PE, tension pneumothorax, pericarditis with tamponade. Okay, esophageal rupture and perforated peptic ulcer. Does this sound like it could be any of those? Yes. Who has thoughts on what? Okay, could be ACS. What else could it be? Okay, could be tamponade. Why are you saying that? Okay. What symptoms in particular are progressive? Okay. So let's look a little further. So he's tachycardic but normotensive. O2 sat is slightly low. In mild distress from the chest pain, leaning forward while in bed. Okay. Those are the labs. And that's the reading of the chest X-ray, which we'll see may or may not be accurate. So does this help you at all? Not that much. Here's the EKG. Is it normal? What's abnormal about it? Okay, so someone said ST elevation. Where? Diffuse ST elevation, I hear. Is there ST elevation in AVR? Oh, there's reciprocal depression in AVR. What else do you notice in AVR? How's the PR segment? It's elevated. Is there PR depression elsewhere? How about in lead 2? Yeah. Okay. So what do we think? All right. So remember, not all ST elevation is ischemia. Whether it's concave or convex up matters. Okay? So if you look, acute pericarditis, acute MI, and benign early repole, okay, the concavity versus convexity is varying. Okay? Similarly, you're not going to have PR depression unless you have a pericarditis. okay? And your T waves will be upright in pericarditis, whereas they're probably going to be abnormal in acute MI. Okay, so what if you also saw that on his rhythm strip or his EKG? That's electrical alternans. Why does that happen? And why is it swaying within the sac? Yep. Yeah, and if there's a big pericardial effusion, there's room within the pericardium for the heart to swing. So what accounts for the voltage? Why is the voltage different? Yeah, simply because the heart is closer to or farther away from the EKG leads, depending on where it's swinging. Okay? What does the ultrasound show? Say that again? Okay, so it shows pericardial effusion, and, not that it says so right there, but what else does it show? You see the right ventricle is significantly bowing in, even to the point where it's collapsing. So this is pericardial effusion with pericardial tamponade, okay? So this is pericarditis with pericardial tamponade. In retrospect, the guy was sitting up and leaning forward. People tend to say that that makes their pericarditis feel better. Should the chest X-ray be normal in this case? Yeah, it can be, okay, but usually hemodynamically significant pericardial effusions you can see. But if it's subtle, your chest X-ray may be read as normal. And the moral of the story there is you should always look at the chest X-ray yourself, because you are seeing the patient, and the radiologist may not notice very subtle things that you might pick up on because you know what you want to see.
Also, the volume that exists isn't always the significant factor. It's also the rate of change. If they quickly
very good.
The fluid, then that would still look normal, but
That's true. Exactly. Okay. So what do you do next? Well, it's a big 7, so you're going to get your attending involved. You're going to complete the workup, and you're going to begin initial treatment. So how do you treat pericardial tamponade?
Emergently or urgently?
Okay, so that's a good question. So either one. Okay, good. That's right. So you got to get the fluid out, and you have to volume resuscitate somebody. Okay, so we'll get there. So these are the diagnostic criteria for pericarditis. You need 2 out of 4. This is right out of UpToDate. Chest pain, rub, EKG changes that are suggestive, and new or worsening pericardial effusion. Okay? How good is your history and physical exam? Well, 95% of patients with pericarditis are going to have pain. Okay? Classically, it is sharp and it is pleuritic. Most people will say, though not everybody, that it feels better when they sit up and lean forward. Okay? As far as rubs go, they're not sensitive. Okay? They're hard to hear. I've seen plenty of patients with pericarditis, and I couldn't hear a damn thing, okay? But when you hear it, it's pretty specific. They also can come and go. They can change with position, okay? So if you hear it, it's significant. The EKG is pretty diagnostic. You should know that it does progress through 4 stages. Typically, patients will come for evaluation while they are in stage 1 because it's annoying to have pericarditis. And what you see is widespread concave up ST elevations other than in AVR where you see reciprocal ST depression. You'll also see widespread PR depression other than AVR where you'll see PR elevation. As a hint, the PR depression tends to be most pronounced in lead 2. Okay? That lasts 1 to 2 weeks. And then the EKG progresses through stage 2 and 3, eventually after several weeks returning to normal in stage 4. So you should know that patients with chronic pericarditis will not have that classic EKG. So if they've been having pericarditis for months and all of a sudden it's recurrent, maybe because they were tapered off their meds too quickly, the EKG will not look the same as if it was acute. Okay, now, everyone with a diagnosis of pericarditis should get an echo. They don't necessarily need an echo right this second, Okay, so sometimes it's appropriate, if you're seeing a patient as an outpatient, to schedule them for an echo in the next day or the day after. But if echo is available, you should get it as soon as possible. Okay? Now, when do you pericardiocentesis someone? Okay, so Seth, your question was, are we treating this emergently or urgently? So if it's emergent, you're going to need to pericardiocentesis it quickly. When would that be? If they have tamponade, if it's a very large or symptomatic effusion that's refractory to medical treatment, you may need to do it faster, okay? Or if you don't know what the diagnosis is, okay, you need to get fluid. Okay, so how do we treat pericarditis? There are usual patients, there are post-MI patients, and there are refractory cases. In the usual patient, you want to put them on an NSAID with colchicine, okay? The NSAID should be relatively high dose for 2 weeks, and then they should have a long taper. We're talking months, okay? 4-week taper, not long enough. Most authorities recommend like 5 to 8 weeks, sometimes 12 of a taper, okay? You can adjust it depending on how people are doing. And colchicine, for 3 to 6 months, no taper. You can just stop the colchicine. If you taper the NSAIDs too quickly, or you don't taper them at all, a lot of this will recur. Okay? Post-MI patients, the recommendation is to use aspirin rather than colchicine, because remember, aspirin is an anti-inflammatory also. Okay, so you would give pretty high dose aspirin, 650 to 1,000 milligrams, 3 times a day with a taper, okay, with colchicine. If it's refractory, okay, that is the only instance where you're going to throw somebody on prednisone. Prednisone should be saved for refractory cases, because if you put all comers on prednisone and you taper it too quickly, it recurs all the time. Okay, so that's a chart from UpToDate that basically says the same thing. Okay, the EKG classically in pericardial effusion will show low voltage. It will often be tachycardic, and you can see electrical alternans. It's impossible to go online and find an example of pericarditis with electrical alternans. I looked all over the place, okay? But if a patient has pericarditis with tamponade, and you look at their EKG, they'll probably have stigmata of both, okay? So they'll have the diffuse concave up ST elevations other than AVR with reciprocal depression and AVR, the diffuse PR elevation other than AVR with PR depression, and they'll probably be tachycardic with low voltage and electrical alternans. What do you think about the chest X-ray? Is it a normal size heart? No. Okay. And it has that characteristic water bottle appearance. Okay. That's a CT. Okay. So you can see that thick area around the heart with a density that almost looks like soft tissue, but not quite. So that's fluid. That's fluid in the pericardium. That is a pretty large pericardial effusion. Okay. You can even see evidence of hemodynamic significance on CTs. There really isn't any here, but you can see some bowing of the right ventricle and there is maybe a tiny, tiny bit here, but you can see it. Okay, and here's another example of ultrasound. Okay, so pericardial effusion, it can be emergent with a percutaneous pericardiocentesis or surgical via pericardial window. Okay, so how do you do this? Okay, what you do is you go just lateral to the xiphoid process in the paraxiphoid area on the patient's left side. Okay? You put the syringe about 15 degrees off of the skin and you aim for that left shoulder. It is very advisable to do this under ultrasound guidance, okay, with a parasternal view, so you can watch the needle enter the pericardium but not biopsy the myocardium, okay? So you would hold back pressure and you would be able to see a flash when you got in, but you'd also be able to watch the needle approach. And if you're doing this, it is probably a pretty big pericardial effusion, so there'll be a considerable distance between when you penetrate the pericardium and when you would penetrate the myocardium, okay? You really shouldn't need ultrasound guidance to do this, but it's always a good idea. Okay, so questions about pericarditis with tamponade.
For pericarditis treatment, what if they can't have NSAIDs or GI bleed history? Would you go right to prednisone?
Well, the problem with prednisone and GI bleed is that it's not so good either.
Yeah.
So it really depends on the patient. Sometimes you can PPI them, okay? Sometimes you might try to treat it without the NSAID or the prednisone and just use colchicine. It's really risk-benefit analysis. So if the patient has recurrent life-threatening GI bleed, you're probably going to err on the side of omitting things that could worsen the GI bleed. If it was a remote history of GI bleed or they have really bad gastritis, you could trial them on acid suppression therapy with the NSAID and the colchicine and see how they do. Yeah, sometimes it's not black and white. Other questions?
In the setting of pericardial effusion without tamponade, and the patient who also has some pleural effusion and heart failure, is it safe to give any amount of Lasix?
Yes, as long as it's not, yeah. So you don't want to overly preload reduce somebody with a hemodynamically significant pericardial effusion, right? Because then they can get hypotensive on you. But if the pericardial effusion is small or even moderate, and they have pleural effusions and they're in heart failure, it may respond to diuresis, and you may not need to pericardiocentesis them at all. Good question. Other questions? All right, so next case. You're the ICU intern, and you're called to the ED to assess Mr. Jones. He's 55. He has a significant past medical history of COPD. And he comes in with an acute exacerbation and hypercarbic respiratory failure. In the ED, he gets several duonebs, Solumedrol, magnesium, Levaquin, and is put on BiPAP. He did well, but now he's complaining of new acute onset right-sided chest pain worse with breathing. Is there a big 7 on your list here? Good. What is it? Tension pneumothorax. Okay. By the way, why did he get magnesium?
Muscle relaxation,
It's a smooth muscle relaxant, and how does that help your lungs?
bronchodilation.
Yeah, it causes bronchodilation. So what's FEV1? Okay, so does anybody know what magnesium does to FEV1? Improves it by 15 to 30%. That's why it's given. Okay, anyway. So on exam, he's tachycardic, he's hypotensive, he's tachypnic, he's hypoxic, he's in mild distress. You hear decreased breath sounds on the left side, and the trachea is deviated to the right. He's tachycardic. Does this help? His chest x-ray was read as NACPD. Okay, but that was probably done before this happened. Okay, so what do we do about this? Do we get a... So we're going to decompress him. You going to do that without a chest x-ray? Yeah, you are. You definitely are. Okay. Is there another option, by the way, besides chest x-ray or CAT scan? Yeah, you know, you can bedside ultrasound somebody, look for pneumothorax. It has equal sensitivity. It's operator dependent, but, you know, once you've seen what pneumothorax looks like, especially if it's a big pneumothorax, like tensions tend to be, you're not going to miss it. It's pretty sensitive. Okay. So that's the repeat chest x-ray. How do we feel about that? Yeah. Yeah. Now, so which side is the pneumothorax on? Good. Okay. Now, does it look like there's a component of tension here? So you're saying yes, right? Okay. So if you look at the upper aspect of the trachea here, it's only deviated slightly to the patient's right because it's fairly right over the spinous processes, okay? But as you look further down, okay, the trachea is really deviated, okay? Plus, last time I checked, that's not where the heart's supposed to be, okay? So this definitely has tension component, but just a pearl is don't get fooled just looking at the top of the mediastinum and say the trachea is midline. If you look further down, the trachea does not stay midline, nor does the rest of the mediastinum. Okay. So we suspect tension pneumothorax. What do we do next? Yeah, we're going to call somebody, we're going to confirm it, and then we're going to begin treatment. So how do you decompress this? Okay, so I heard two things. So yeah, pigtail is going to take a little while. So when it's a tension, we will often if they're unstable, which they usually are, especially this patient, we're going to needle decompress. And you said you put it in the what? In the second intercostal space, where? Midclavicular line, relative to the ribs, where? Huh? Right over the rib. Why not right under the rib? Yeah, so that you don't want to do that. The intercostal arteries actually bleed a lot, and they're not really tamponadable because they're in a little nook. So the only person who's going to fix that problem is IR. I've seen people exsanguinate pretty viciously from chest tubes gone wrong. So yeah, always over the rib. Okay, so pneumothorax. There are two flavors. You can have a primary spontaneous pneumothorax or you can have a secondary spontaneous. The primary spontaneous just means you can't identify a reason for it, okay? Most of the patients who have these things that are secondary, they'll have COPD, asthma, or something else going on, okay? History and physical exam. You know, in small pneumothoraces, it can be really subtle. Physical findings and really subtle history. But when patients are symptomatic, they'll usually complain of chest pain, sometimes back pain. As the pneumothorax gets bigger, they'll start to get dyspneic, okay? On physical exam, I mean, there are a lot of findings here, but again, they can be quite subtle. Fremitus. Do you guys routinely test for that? How about egophony? Okay. So, you know, you should have a good arsenal of physical exam skills. Bust some of that out when you're thinking about something like this. I mean, I definitely do not test fremitus on all patients, nor do I test egophony on all patients. But, you know, in patients who I think may have subtle pneumonia, I'll do some of that stuff. In patients who I think might have a subtle pneumothorax, I'll do some of that stuff. So, you know, if it's in your playbook, use it sometimes. How do you diagnose this? Well, chest x-ray and ultrasound have pretty good sensitivity, but CT is much, much better. Okay, so here you've got a, where's the pneumothorax in the chest x-ray? On the right side. Is it tensioning? Yes. Yes. Okay, and then you can see this pneumothorax on CT, pretty darn obvious. And now this is ultrasound. It is very, very difficult to show you what ultrasound looks like unless I show you live, okay? But basically, there are two levels of pleura in the lung, right? What are they? Okay, and so there's a potential space between them that's pretty small in a normal person. And so when you have an inspiration and an expiration, the pleural layers will slide over each other and they will scintillate on ultrasound. We call that lung sliding, okay? And you can see that in the ultrasound image on the right, you'll see this line right here. That's the scintillation from pleural sliding, okay? And on the right, you don't see that, and you won't, okay? Now, it's pretty obvious. You only see it, so you have to, when the person breathes. So you've got to say, take a deep breath. You look right between the ribs for that lung sliding. And in pneumothorax, you don't see it. Now, what they did is they're measuring the excursion, okay, on the bottom, okay? And you can do that with ultrasound. All right, so how do you size pneumothoraces? How do you measure them?
You measure the space from the chest wall to the lung.
Okay, and you measure it in centimeters, okay, at the level of the hilum, and you put it into, there are different ways to do this, but one way is you put it into 3 categories. So if it's less than a centimeter, it's very small. If it's between 1 and 2 centimeters, it's small. And if it's greater than 2 centimeters, it's large, okay? And you should know that a pneumothorax that's greater than 2 centimeters is about a 50% pneumothorax, okay? So it's important that we size it correctly because that plays into treatment. So how do we treat that? Ludmilla, you gave one example before, right? You can put a pigtail in, okay? Which is a type of thoracotomy tube, right? It's a type. It's a small one. What's the other option? Is there another option? Do nothing is one other option. And what's another one?
Large bore chest tube.
Okay, so let's consider tube thoracostomy one option, whether it's a teeny weeny piggy or it's a big one. Then we got do nothing. There is one other thing. I'm kind of glad you guys aren't saying what it is. Yeah, that's sort of the watch it phase. You can aspirate the air. Have you heard about this being done? Have you seen it being done? Yeah, there's a reason for that because it doesn't really work that great. Anyway, so we talked about needle decompression for tension. You want to make sure that you use a big needle. Okay, you can use a 14 gauge angiocath. If you use an 18, a 20, it's going to collapse and it is not going to work. It has to have some bore, okay? And then you would follow that with a chest tube. For a stable pneumothorax, okay, you put somebody on oxygen and then you've got to drain that air out, and here are your options. For a large and symptomatic one, you really need to do tube thoracostomy. For small, you can either do a tube thoracostomy or needle aspiration. And if it's very small, you can watch it. So you can put someone on oxygen and you can check serial chest x-rays, okay? So tubes versus needle aspiration. Tube thoracostomy has a higher success rate, significantly, okay? The reason why people consider needle aspiration over tube thoracostomy is that traditionally larger bore chest tubes were used, and that is painful, okay, and can have complications. Now, what we've noted is that smaller bore tubes work just as well in almost all patients, are much, much easier to put in, are a lot less painful, and have less complications. So if you're choosing between needle aspiration and a huge-ass chest tube, there are some advantages to needle aspiration. But when you can insert a pigtail using the Seldinger method, okay, it's pretty non-invasive compared to using a large bore chest tube with the traditional insertion mechanism. And so most people are shying away from needle aspiration, okay? Here's your landmarks for where to put the needle decompression. What intercostal space, by the way, is marked in the picture on the left? It's the second. It's a little confusing because that's the clavicle. Okay? So that's still the second intercostal space in the midclavicular line. That guy has an open chest wound. Okay? So they stuck a tegaderm on it. Okay. So questions about tension pneumothorax. Has anybody seen a case of tension pneumothorax? What you should know is that patients can convert pretty quickly from a simple pneumothorax to a tension pneumothorax. What happened with this patient? They came to the ED, they were doing better, and then what happened? They got positive pressure ventilation. So they may have had a small pneumothorax, all right? COPD patient having an exacerbation. They may have had a small pneumothorax and then they got put on BiPAP. So they got positive pressure ventilation. That's a wonderful way to convert a pneumothorax to a tension pneumothorax. Okay? Or it may have been that the BiPAP gave them barotrauma and they developed a pneumothorax that then converted to tension. But you should know that it can happen really quickly. And a tension pneumothorax can cause hemodynamic instability very fast. So it's a pretty bad thing, which is why you just decompress them. If clinically they look like they're tensioning, you decompress them. You don't wait. You just do it. Okay, case 6. The patient's 45, significant past medical history of heroin abuse, comes to the ED complaining of nausea, vomiting, and diarrhea for 36 hours, and then 18 hours of worsening chest pain. The pain is 10 out of 10, sharp, retrosternal, and constant. Okay. This patient has a fever of 102.4, a heart rate of 130, blood pressure of 92/46. He's tachypnic. Does he meet diagnostic criteria for SIRS? How many SIRS criteria do we have there? 3. We have 3. We have temperature greater than 100.4, right? Or less than 96.8. We have heart rate greater than 90. We have respiratory rate greater than 20 or PaCO2 less than 32. The only SIRS criteria that we don't see here until we get to the bottom is white blood cell count over 12, less than 4, or bands greater than 10%. Okay. Does the patient have any Q-SOFA criteria, by the way? And what the hell is that, you might ask? Who knows what Q-SOFA is? Yeah, so there's a lot of chatter about the lack of sensitivity or specificity of the SIRS criteria, and there are several proponents of replacing them with something called the Sequential Organ Failure Assessment Score, SOFA. And Q-SOFA is quick SOFA, and there are 3 components of it. Who knows? Anybody know what they are? Altered mental status. Okay. That's right. So tachypnea, hypotension, and altered mental status. So this person would have 1 because they're tachypnic. Okay, anyway. So when you get to the exam, there's mild distress due to chest pain. The lungs are clear. There's crepitance of the anterior neck. He's tachycardic. Extremities are cool. And the guy has a leukocytosis with a bandemia. So what big 7 is this? Yeah. So do you always have a fever with Boerhaave? No. So what is this? Boerhaave with a side of? Yeah, well, probably the person has Boerhaave because of the withdrawal and the recurrent vomiting. So let's think it through. Is it good to have a rip in your esophagus? Why is it not good? Right. So you can get a chemical mediastinitis. Is this a chemical mediastinitis? No. This may have started as a chemical mediastinitis, but now this person has bacterial mediastinitis, and they may be bacteremic. They certainly meet diagnostic criteria for sepsis because we're suspicious for infection. Okay? That's the chest X-ray. Can you see anything wrong with this chest X-ray? Well, let me ask you. What's this? What are these 2 things? One goes down here, one goes kind of up here. These are leads. Okay, well, what's this? See that? Is that a lead? It could be fluid. It's probably more likely air separating the pericardium from the wall of the heart. This is a pneumomediastinum, okay? This is very subtle, okay? This is why you read your own chest X-rays, because when you have this patient come in and you order the chest X-ray, you are looking for pneumomediastinum. It is very easy to miss that if you just think you're getting a chest X-ray for somebody who has standard chest pain, okay? That's the CAT scan. Can you see the pneumomediastinum now? Yep, okay? So there's air in a lot of places where it shouldn't be, like all in here. Okay, so this looks like esophageal rupture with mediastinitis. Okay, so first of all, Boerhaave syndrome is really rare, okay? 3.1 per 1,000,000. What causes it? A sudden increase in esophageal pressure combined with negative intrathoracic pressure. So when can you get this? Most people get this from recurrent vomiting. But it's also been pulled off in other mechanisms like childbearing, seizures, a lot of Valsalva-ing during weightlifting, okay? It's been reported with patients who are coughing repetitively, or I guess it's dangerous to laugh too hard. And when you rupture the intrathoracic esophagus, it contaminates the mediastinum with gastric contents, okay? then that starts chemical and becomes bacterial. There's usually an inciting event. In 25 to 45% of patients, it's vomiting. Patients will then get chest pain. They'll have odynophagia. They'll get dyspneic. They can have crepitance of the subcutaneous tissue. You can hear something called Hammond's sign. I've listened for it in patients who have had esophageal rupture, and I've never heard it, probably because I've only seen a few patients with this. But apparently you can hear the crepitance with each heartbeat. Okay, so S1, S2 with a side of Rice Krispies. All right, and then the patient, if they have bacterial mediastinitis, they're going to be septic. You can see this on chest x-ray if it's bad and if you pay attention. You can see it on CT. You want to get a gastrograph and esophagram. Now, when we get esophagams, do we usually get gastrograph and esophagams? What do we usually get? Okay, we usually get barium esophagams. Why do we get gastrograph and esophagams when we're ruling out Boerhaave syndrome or esophageal? Good mumbling, excellent. Yeah, because the barium is caustic. Okay, it will cause a chemical mediastinitis if you don't already have one, which you probably already do. So what do you do with these people? NPO, analgesia, lots of IV broad-spectrum antibiotics. You want to PPI them, and you need some help. Okay, so you want a CT surgeon, because that CT surgeon will very likely need to intervene if they have bacterial mediastinitis, even potentially with chemical. They may need to drain the fluid, debride the necrotic tissue, and they may need to repair the rupture in one way or another. Okay? Now, you should get GI on board too, because sometimes the preferred way of repairing this is endoscopic rather than open. And it really depends on the clinical condition. And it's something that you're going to want those two specialists to talk about. Yeah?
Antiemetic as well?
Yes. Yes, definitely. If they're still barfing, you want them to stop barfing. Okay, so case 7. What's the diagnosis? Based on process of elimination? Okay. 48-year-old male, significant past medical history of gout, comes to the ED complaining of chest pain and vomiting blood. His abdominal pain started 2 weeks ago and has been steadily worsening. This morning, even though he took 1,600 milligrams of Motrin, it got worse. He then vomited bright red blood. He drove himself to the hospital and reports that his belly pain is so bad that he can't walk, because it hurts when he takes steps. He reports that he's been taking Motrin and prednisone for his gout. He reports black tarry stool for the last few days, and he's very uncomfortable. Diagnosis? Yeah, ulcer that has probably... What in the history makes you think that it may have perforated? Okay, so he has peritoneal signs, right? The abdominal pain is really, really, really severe, and the hurts while he's walking is probably a manifestation of rebound. Okay. So he's tachycardic, hypotensive, tachypnic, looks bad. Okay, his belly is rigid, diffusely tender to superficial palpation, has rebound and guarding. His stool is melanic, and it's guaiac positive, and his extremities are cool. Okay, labs are pending. That's his chest x-ray. How do we feel about that? Free air. The fancy term for free air is pneumoperitoneum. And do you see it on both sides? Yeah, so there's air under both hemidiaphragms, okay? Okay, so peptic ulcers can complicate, okay? You can get gastrointestinal bleeding from them. That is the most common complication. They can perforate, they can penetrate, they can scar and cause a gastric outlet obstruction. The major risk factors for this happening are NSAIDs, prednisone 2, and H. pylori, okay? So patients who do perforate, they tend to go through stages, okay? And you should know that patients look differently depending on what stage they're in. So initially, it's pretty dramatic, okay? Between 0 and 2 hours, they have really, really bad abdominal pain, peritoneal signs, and their pain, which usually is localized when it's just the ulcer, okay, will become very generalized once it perforates. If they present late or the diagnosis is missed, okay, after about 2 hours up until about 12, their symptoms actually get a little bit better, Okay? But then, when you're getting over 12 hours, they'll start getting abdominal distension, and they'll start going into shock usually. And it'll be a combination of hypovolemic shock from leaking of gastric contents and hemorrhage to septic shock. Prognosis is pretty good if you catch this at the early stages, but if it goes too long, it gets worse. Okay? You can see perforation when it's bad on a chest x-ray or an abdominal x-ray, but they're not sensitive enough to see smaller or early perforations. And if it penetrates posteriorly, okay, into the retroperitoneal space, you're not going to see free air. So you need a CAT scan to see the subtle things, and you need a CAT scan to see if it penetrates posteriorly. Okay? So here, the arrows point to air that really shouldn't be there. Okay? How do you manage this? You want to hemodynamically stabilize somebody with isotonic IV fluid. They may need blood. Okay? You might need to intubate them if their airway is unstable. Most of these patients are going to get whisked off to the OR. So oftentimes we will intubate them understanding that the clinical course is probably going to be rough, and they are going to get intubated anyway in the OR. So sometimes we do it sooner rather than later. They need PPI, they need broad-spectrum IV antibiotics, and you need a surgical consultation, okay? Most of these are going to get repaired surgically, okay? Occasionally, it will not be managed operatively, okay? And GI should be on board. Have any of you seen a case of perforated peptic ulcer? How long did it take to get them to the OR?
They actually, she was like, her pH was like 7.1, her potassium was like 7.1 as well, so they did dialysis on her, and then they took her up to the.
So they stabilized her first, yeah. Okay, so to review, those are the big 7. I would memorize them, and I would always be paranoid when you're seeing somebody with chest pain that it could be one of those big 7, okay? Your job is to rule out the big 7 first, then make a diagnosis later. It's more important to rule out badness than make a definitive diagnosis in the early stages of a patient's interview. How do you rule these out? On the basis of a history, physical exam, ancillary studies, and in some cases, clinical decision-making rule. Okay? Once you've either ruled it in or ruled it out and made a diagnosis, you begin treatment. Okay? Questions? All righty. We're done early today.